Yeah, so now till we have discussed that if a patient, old age, sudden onset, severe headache with a stuporous, comatose behavior with a neurological deficit may not be present, is a strong suspicion for cervical hemorrhage. And as we have seen, the investigation of choice would be a CT plane or preferably a CT angiogram. MR-angio, if done, if possible, can be also be done, but most specific and sensitive is CT angiography, which not only shows the bleeding in the subarachnoid space, but also a ruptured and other existing aneurysms as well. The CT non-contrast showing blood in the basal system is star sign. The star sign is a very sensitive or a specific radiological appearance for blood in the cisternal space and subarachnoid space. So, as you can see in the picture, the subarachnoid, a large collection of a blood or pouch, outpouching in the blood is seen, which is a ruptured subarachnoid aneurysm and which has caused the bleeding. Now, coming to the management of subarachnoid hemorrhage, we have to take care of two things. Mainly the treatment of aneurysm, and secondly the treatment of aneurysmal bleed and its complications. Now, the first is acute care. The patient with a severe onset headache that has come to the neurological ICU, who is stuporous or comatose or may have seizures and may have a signs of raised intracranial tension, has to be managed acutely with a conservative management. The standard guidelines: first we have to secure his airway, then breathing and a circulatory support. All patients' vitals are measured, and if there anything abnormal, if the patient is having a severe hypertension, the hypertension has to be taken care of. The patient is comatose, the patient may require a ventilatory assistance. A routine 8-hourly and on the presentation arterial blood gas analysis has to be done. Emergency CT scan or probably CT angiography as per availability we have discussed earlier. The patient needs a continuous cardiac monitoring and the pain management. If the patient is in coma or a stuporous, the pain is not a big issue, but if the patient is conscious oriented, is complaining of pain, the patient has to be given a very broad spectrum pain relief management, which may comprise of a Dynapar, which is called a Voveran, or a ketorolac, or may have to be given a general anesthesia if the patient is not able to bear the pain. The goal of treatment is to prevent the rebleeding and the cerebral vasospasm. The rebleeding and cerebral vasospasm, they both are dreadful complications of a ruptured perianeurysm, and it occurs most commonly between 7th to 14th day of the bleed. The rebleeding, what happens that when the aneurysm bleeds, the bleeding site is pegged by a small clot or a platelet activation, which pegs the bleed. But as the patient gets a bout of hypertension or the blood flow increases, the clot is dislodged, and that ruptured aneurysm bleeds again. The rebleeding carries a very high level of mortality and morbidity and has to be prevented at all the cost. And second complication is a cerebral vasospasm. The cerebral vasospasm occurs because the blood that has ruptured from the aneurysm, it causes the intima and the media to go into a spastic stage, and the blood flow of the arteries that are penetrating the cerebral substance from the subarachnoid space, they go in spasm and cause infarcts, and it presents as ischemic infarcts. So these both two have to be prevented: the rebleeding and cerebral vasospasm. The patient has to be given complete bed rest, and if the bleeding is torrential and is not responding to medical measurements, the patient has to be given a recombinant factor 8. For the medical management, the calcium channel blockers is the mainstay of therapy. The nicardipine or nifedipine is used conventionally. The better medicine as regards to management of subarachnoid hemorrhage is nicardipine. The smooth muscle relaxants are to be given so as to prevent the vasospastic events that occur after the bleeding of aneurysms. And the three things that are to be maintained, which we call as a triple H therapy: hypervolemia, hypertension, and hemodilution. So the patient has to be given well hydrated, the hypertension is to be managed, and unnecessary hemodilution has to be avoided. Now the steroids are used to manage subarachnoid hemorrhage. Basically, the purpose of steroids is to reduce the intracranial tension, intracranial pressure that happens. And second mode of action of steroids that is to be given is to prevent the formation of fibrous tissue because of blood in the subarachnoid space. The steroids also reduce vasospastic events because they reduce the inflammation that is created by the blood in the subarachnoid space, and they help to maintain the blood pressure also. The antihypertensives are empirically or judicially given so as to maintain the blood pressure of patients and to avoid any hypertensive episodes which may cause a rebleed. The choice of hypertensive depends on patient profile, risk profiles, and its other parameters. But as such, calcium channel blockers are preferred because they also prevent the vasospastic events. The subarachnoid hemorrhage is associated with hyperpyrexia. It is classical of SH, and the antipyretics like paracetamol or cold sponging are to be done. Empirical anticonvulsants, if the bleed is large and the patient is at risk for seizures, empirical anticonvulsant therapy is also indicated, and it is must if the patient present with seizures. Any broad spectrum antiepileptic can be given. The choice of antiepileptic on the first incident is fosphenytoin, then sodium valproate or levetiracetam. One caution has to be taken while prescribing anticonvulsant is that it should not be a sedative one, so that the patient may not get sedated and it may not interfere with the evaluation of the patient's consciousness status. A broad spectrum, broad analgesia has to be given to the patients, which may include high level of anti-analgesics like injectable ketorolacs or injectable Vovarans or even tramadol. In some patients, intravenous morphine has to be given if the patient pain is unbearable, and a sedation so as to reduce the anxiety of the patient and his overall mental state has to be given. The stool softeners are routinely prescribed to all patients, either in the patient in the ICU or even after discharge of a patient of SAH, so that he may not have to strain while defecating and it may not lead to hypertensive episodes or hypertensive crisis. A stool softener is a must. Now, if a patient presents with a worst headache, the patient says that if the patient headache is the worst of his lifetime, then there are several differential diagnoses that have to be considered. One of the most common and most important is migraine. Acute severe migrainous episode is exactly, it mimics the subarachnoid episode. The second headache that and a cluster headache, both acute classical migrainous headache and acute cluster headache episodes also create the worst headaches of the lifetime. The patient complains that he had never had such a headache, and both are these important differential diagnosis in subarachnoid hemorrhage. Now, arterial dissection is also a very important differential diagnosis, and the arterial dissection can be detected only by doing a sensitive either digital subtraction angiography or magnetic resonance imaging. The vasculitis episodes that occur in patients that create the vasospasm events and cause stroke and severe headache are also seen in autoimmune disorders. The drug abuse and anticoagulant use, they also both present with very severe headaches and come in the differential diagnosis of subarachnoid hemorrhage. The pharmacological treatment of a patient that presents to the ICU, first we have to put a central line and then we have to monitor his central venous pressure. If it is less than 7, then 9.9% normal saline is given. Ideally, we have to maintain the CVV between 7 to 10. To maintain also the blood pressure has also to be maintained. The systolic blood pressure should be kept between 140 to 130 until the aneurysm is secured, and the diastolic should be kept around 90. If it is non-traumatic, then the vasospasm should be controlled with the nimodipine 60 milligram 6 hourly or 4 hourly for 21 days or 30 milligram 2 hourly for 21 days as per the hypertension monitoring of the patient. To prevent the seizures, a levetiracetam 500 milligram 12 hourly should be given, and constant monitoring of arterial blood gases and glucose is to be done. Now, the nimodipine is a drug of choice for calcium channel as a subarachnoid hemorrhage, and it is a calcium channel blocker. It prevents entry of calcium into the smooth muscles during depolarization, which inhibits the vasoconstriction. Mainly, it is used as an antihypertensive in SH because it is a drug of choice to prevent vasospastic episodes. It is given 30 milligram per hourly, 2 hourly for 21 days, or 60 milligram 4 hourly for 21 days. 90% of it is protein bound and it is hepatically metabolized, and with it, a constant neurological monitoring has to be done. Now, when the patient is discharged of a very aneurysmal rupture that is stable and has no further vasospastic or a rebleed event, and a CT angiography shows a large aneurysm that has prevent bleeding again because of a package by a clot, or another aneurysm that is present concomitantly, then the patient has to be given the benefit of surgical management, which is ideally done by clipping of the aneurysm or by coiling of the aneurysm. In clipping of the aneurysm, a catheter is put via radial artery or a femoral artery that passes into the carotids and then directly goes to the brain to the bleeding site, and a clip is put at the base of aneurysm to secure it. Another option for a aneurysm that has either unruptured or has stopped bleeding after rupture is a coiling. A coil of a metal is put inside the aneurysm so that it causes the stasis of blood in it and the blood clots. Both are good options, and it depends patients. A large aneurysm has to be preferentially clipped, the small aneurysm may go for coiling. Now, infectious problems in subarachnoid hemorrhage patients. Important to distinguish SH from a mycotic, that is bacterial aneurysms, or post-infective aneurysms. If the aneurysm is because of some secondary infection, then the patient has to be given proper antibiotic coverage, broader spectrum, with all possible complications of critical illness. And now 6% of the patients of subarachnoid hemorrhage aneurysms, they present with seizures. Now, distinction between convulsive and decerebrate posturing may be difficult. The post-operative seizures occur in 1.5% of the patient despite anticonvulsant prophylaxis. And it is also important to remember to consider other causes of seizures like electrolyte imbalance, raised intracranial tensions, hypothermia, or hyponatremia in a patient of SH. The patients develop ischemia late in the course of SH, mainly because of vasospasm, and the late seizures may occur in 3% of the patients. Now, the patients of a subarachnoid hemorrhage has to be taken care for rebleed, hydrocephalus, intraventricular hemorrhage, increased intraocular tension, intracerebral hemorrhage, seizures, and vasospasm. The complications of SH that may happen with SH is respiratory complications like aspiration can happen, or the patient, if he has a raised intracranial tension so much, then the bleed, because of bleed, the respiratory drive may reduce. The patients may have a cerebral venous thrombosis. Patients may end up in hyponatremia or hypovolemia. The hyponatremia is a predominantly a very important clinical feature of SH and presents with SIADH. And patients may have severe gastritis or gastrointestinal bleeds also. The patient has to be given at least 2 to 3 liter fluid per day with nimodipine and a central line to measure central venous pressure and to measure the hypo patient. Hyponatremia has to be taken care of. The seizures have to be taken care of. So this is all regarding subarachnoid hemorrhage. Thank you very much.